So good afternoon to everybody. And I am going to talk about retinotomies and retinectomies. And basically, the idea is to discuss when to do a retinectomy or a retinotomy and how to perform it. So this talk over the next 10 minutes is going to briefly discuss history and basics of a retinectomy, when to perform it, review some surgical videos, discuss what's the role of adding a sterile buckle in such cases, and then what are some of the causes of a recurrent detachment after you've performed a retinectomy. So I'm sure as many in the audience are aware that retinotomy or a relaxing retinectomy has been around for almost 40 years and was originally described by Bob Malcolmer as a way to achieve complete mobilization of the retina, initially in cases of incarceration following trauma. So when do we perform a retinectomy? So the idea is that a retinectomy is not a substitute for adequate membrane removal in cases with proliferative retinopathy and recurrent detachments. The idea is that when you have circumferential retinal shortening or you have radial retinal shortening, you may need to perform a relaxing retinectomy in order for the retina to lay flat. And the idea is we want to perform a retinectomy that is large enough to achieve that purpose, and that does involve extending into the normal retina as well. So there are also cases where you may not necessarily need to perform your typical SMILE inferior 180 retinectomy, but a more localized retinectomy may be adequate. And these are areas where the area of contraction is not released after the initial membrane peel, and the retinectomy in that case needs to extend anterior again into the unaffected retina. So what about cases of a localized retinectomy or a retinotomy? These are cases where if you have focal retinal incarceration, for example, you have a very dense star fold that is adherent and with extensive intrinsic contraction, or there is an area of trauma with the retina incarcerated, you may be able to get by performing a localized retinectomy in those cases. Another situation where a retinectomy is helpful are in cases where you have rolled edges in a giant retinal tear. So when you have a large retinal tear with rolled edges that prevents complete unfolding even under perfluorocarbon, you may want to trim the edges of the tear in order to extend the natural retinectomy that is performed, and then also similar to other concepts in retinectomy, extend it a little bit into the healthy retina depending on the position of the tear. One of the important points to remember when you're performing a retinectomy is the importance to avoid slippage. Now, slippage occurs when your retina is not adherent to the RPE where it needs to be, and therefore will slip posteriorly during the case. So there are various strategies that can be adopted to avoid this. And one involves, these are cases where perfluorocarbon is essential in order to get the retina to lay flat and to achieve that at the end of the case. So you can try to avoid slippage by carefully drying the edges of the retinectomy while performing your fluid air exchange. And this is really, these are really cases where meticulous drying of the edges all along the edges of the retinectomy and being patient in doing so helps. The other option in such cases is to perform a direct exchange where you fill the eye with perfluorocarbon and then exchange it for silicone oil. And that can be done passively, where you let the perfluorocarbon vent as the oil is injected, or actively, where you're simultaneously injecting silicone oil and actively aspirating the perfluorocarbon. So let's look at some surgical videos. So this is a relatively young female with a macula involving retinal detachment, hand motion vision, has undergone a buccal vitrectomy with gas previously that you can see has failed. So these are cases where, again, you need to be generous about performing lens removal or at least rendering patients pseudophakic if they haven't been done so. Removing the anterior capsule, residual capsule is important to prevent anterior proliferation. So once your process of removing the membranes is complete by whatever method you adopt, including staining, use of bimanual techniques, and then you make a decision about performing a retinectomy. So one of the first steps I like to do is to highlight the margins of the retinectomy. You can do so by applying diathermy. You don't necessarily need to apply contiguous diathermy, but at least to the vessels that are extending across the margin. Then the next is to cut the retina. You can use scissors, but these days with our small gauge vitreous cutters, they are very effective at performing a controlled cut of the retina. And by reducing the vacuum, you can really do this in a controlled manner. This particular case had retained perfluorocarbon subretinal that was removed. Now, one of the things I wanted to highlight in this video is that we went ahead and performed a 360-degree retinectomy. And this is something that you want to avoid before you have stabilized the retina. And you'll see why in just a minute. Because as we're trying to place perfluorocarbon now, we're struggling with getting that to lay over the retina. And in fact, the retina just slides over to the side. Part of the reason for that is that the posterior funnel of this residual retina is still not open. So there's a lot of intrinsic contraction there. So in these cases, if you are in a situation where you've already performed a 360 retinectomy and now your retina is very mobile, you do want to ensure that you've removed all subretinal bands and membranes. And if the retina is still not flattening, you may be able to then go under air and try to get it to flatten as much as possible and then exchange it for oil. But in general, when performing a 360-degree retinectomy, it is extremely important to leave an island that is connected to the anterior retina so that you can maintain orientation of the residual retina, and you can also then fill it up with perfluorocarbon and then complete the separation of the retina. So this is what these patients look like postoperatively. You do see some heme at the edges. This needs to be minimized as much as possible intraoperatively by applying diathermy to the bleeding vessels, and again, watching and carefully cauterizing as much as you can. But they often do reasonably well, as a method of salvage in these cases. You can see this patient at a year out was about 2,400. What about the role of adding a sterile buckle? Now, this seems counterintuitive because if you're going to cut out a large part of the retina, and this applies to up to 180 degrees of retinectomy, then why add a sterile buckle? Now, there are actually some rationale for adding a sterile buckle to support the horns of the retinectomy edges. So again, this has no relevance in a 360-degree retinectomy, but if you're performing up to 180 degrees, it does help to reverse the direction of the vector forces that are perpendicular to the eye wall. And it increases the inward force because the radius of curvature that's caused by the buckle is much smaller than the radius of the eyeball itself. And it provides you that additional support. Now, it is extremely important to remember that if you are adding a buckle for this purpose, the horns of the retinectomy need to be on the crest of the buckle and not the trough. Otherwise, this may do more harm than good. And that is extremely important when you're placing the buckle. There are also some proponents of a primary retinectomy in PVR. And again, this is something that is still controversial. I usually reserve a retinectomy in cases where there has been reproliferation and recurrent detachment after primary surgery. But there may be some argument that if there is too much intrinsic contraction, then an early retinectomy that is performed more peripherally does lead to good outcomes because you're able to salvage more of the retina as you're going more peripheral, and you are able to arrest the proliferative process early on. Now, despite your best efforts, retinectomy doesn't always work. And it is important to recognize what are some of the causes of a recurrent detachment after a retinectomy. And the main reasons are there can be fibrosis at the edge of the retinectomy. You may have performed an inadequate retinectomy. And this is something that we discussed earlier, where it's important to always make your retinectomy larger than what you initially planned. And that's why we often refer to the SMILE configuration for a 180-degree inferior retinectomy. And that does involve extending into the healthy retina for about 20 to 30 degrees. You may form a contractile epiretinal membrane over the retina. You could get anterior PVR in the non-retinectomized area. And that's why it's important to remove this area when you're performing a retinectomy. You can get beyond the edge proliferation. And lastly, severe retinal infolding and then recurrent PVR. So let's look a little bit about what these mechanisms look like. So you can get a star fold or a recurrent epiretinal membrane that causes the edges of the retinectomy to lift up with similar mechanism of the contractile ERM, fibrosis at the edges of the retinectomy, infolding, and then beyond the edge proliferation. So what about fibrosis of the retinectomy edge? This is tangential and occasionally AP traction. And the solution for this is that you really need a nice and clean edge of the retinectomy. And as I discussed, you want to minimize heme at the edge of the retinectomy by carefully applying diathermy wherever there is bleeding. For contractile epiretinal membranes, removing the internal limiting membrane along with the epiretinal membrane is helpful to reduce the formation of recurrent ERMs. For inadequate retinectomy, we discussed that you really need it to be much larger than what you may have originally thought. Otherwise, you may end up with radial and circumferential retinal shortening. For anterior PVR, you need to excise completely the anterior proliferative complex. I prefer excision over applying laser to that residual area. It does remove the tractional element and remove surface contraction. In cases where there are IOLs or there is a residual capsule, you may want to remove that as well. For beyond the edge proliferation, again, it's important to ensure that the retinectomy edge is as clean as possible. And this is thought to result because of all the growth factors that are sequestering the fluid phase. For severe retinal infolding and recurrent PVR, again, meticulously removing the membranes before you perform the retinectomy. Remember that the last step should be performing the retinectomy. All your efforts for membrane removal need to be before that. The one exception is that if there are subretinal bands and membranes, those can be removed after reflecting the retinectomy. There are some pharmaceutical treatment options that are being investigated, including intravitreal methotrexate that is injected as a series of intravitreal injections. And this is currently in a phase 2 trial by Aldera. And it's also important to recognize other factors, like smoking status and potential role of other anti-inflammatory agents. And with that, since the time is up, I am going to conclude. Thank you very much for your attention.